I want to thank everyone for joining us this morning. We have people joining from different places, and so welcome uh, for joining us at this 8 o'clock Central Time in Arkansas. I'm Kim Schuler. For those of you who I don't know, I'm the CEO for the Arkansas Behavioral Health Integration Network, and we are so glad you're here this morning. Today, we're going to have a fantastic presentation on collaborative care in perinatal settings. We have two phenomenal speakers today. We have Sarah Burns, who we know from University of Michigan, and she is a plethora of knowledge. I've had an opportunity to hear her trainings and to hear her speak, and we're so grateful that she's here today. And we have Dr. Music, who's joining us from Austria. And so Dr. Music is phenomenal in her field. I want to remind everyone that this is a recorded training. So by staying on today's call, you're giving us your permission to record this, and we will be posting this to our website. I want to now give an introduction. As I said, we have two phenomenal speakers. We have Sarah Burns. Sarah is the lead clinical training and implementation specialist at PRISM in the Department of Psychiatry at the University of Michigan. PRISM partners with health systems and payers, providing individualized consultation and training to implement the psychiatric collaborative care model. Previously, Ms. Burns served as the Director of Training at Concert Health. In addition to integrated care, Ms. Burns is passionate about suicide prevention. She served as the Director of Suicide Prevention at a network of federally qualified health centers in New York and was instrumental in founding the Zero Suicide Institute at the Education Development Center. Sarah, we're so glad you're here this morning. We also have Dr. Marie Music, who is an associate professor of psychiatry and obstetrics and gynecology at Michigan Medicine. Her work focuses on the impact of stress, trauma, and mental illness in the context of childbearing on caregiving in the developing parent-child relationship, and how to support families in overcoming psychological and environmental adversity. She serves as principal or co-investigator on multiple projects funded by NIH, the U.S. Department of Health and Human Services Administration for Children and Families, Michigan Department of Health and Human Services, and the Centers for Medicare and Medicaid in Michigan. She holds a doctorate in medicine and a master's degree in public health, and serves as the medical director of the Perinatal Psychiatry Program at Michigan Medicine, in charge of the perinatal clinical care delivery, both with psychiatry as well as integrating within obstetrics, family medicine, and pediatrics. Additionally, she is the medical director for MC3 Perinatal, a statewide perinatal access program to primary care, public health nursing, community mental health, and other health providers. She's the co-director of Zero to Thrive, a program and serves to buffer risks and enhance resilience in young children under the age of 5. Within the scope of this work, she has co-developed the Strong Roots curricula, a series of intervention for parents and other caregivers to foster caregiver reflective capacity and enhance their sensitive caregiving, and ultimately to benefit the wellness and health of young children. In 2018, she co-edited the book, Motherhood in the Face of Trauma, Pathways Towards Healing. Dr. Music is highly published with over 140 articles in peer-reviewed journals. Wow. With that, it is my pleasure to introduce and welcome Sarah Burns and Dr. Music. With that, I'll turn it over to you, Sarah.
Thank you so much for those introductions and for all of you joining us this morning. How we're going to spend our time together. So I'm going to spend probably no more than 10 minutes just level setting, reviewing the collaborative care model. And then I'm going to turn it over to Dr. Music to discuss some of the adaptations for using the model with the perinatal population. And then she'll tell you about some resources we have in Michigan that might be similar to what you have in Arkansas, and talk about some of the data that she and her team have collected on their perinatal collaborative care project. So apologies if some of this is review. I realize this is ABIN, so you have a much broader knowledge of collaborative care than other groups, but just in case you're more familiar with some of the other integrated care models, we'll spend about 5 or 10 minutes just as a review of what this particular integrated care model is. So I'm sure you've seen a version of this chart before, the triangle chart, or for us, it kind of looks like a circle. As you know, the collaborative care model is a highly evidence-based model for treating common behavioral health problems like depression, anxiety in primary and specialty care settings like pediatrics, geriatrics, and reproductive health. So the collaborative care model adds 2 new roles to the treatment team, a behavioral health care manager and a psychiatric consultant. And this team collaborates using a new tool, the systematic case review tool. This tool allows the team to use a population health approach to caring for all patients enrolled in the collaborative care program. We're going to look at each role briefly for each team member. So looking at the role of the primary treating or specialty care provider, that's a mouthful. When we teach just primary care providers, we tend to use treating or primary care provider. But when we're talking about other settings like OB-GYN, specialty care provider is appropriate also. So forgive me throughout the presentation if I just shorten that to PCP or primary care provider for brevity's sake. So the primary or specialty care provider remains in control and oversees all aspects of the patient care. They screen for common mental health issues, identifying patients who may be appropriate for the collaborative care program using standardized tools like the PHQ-9 and the GAD-7. When they identify a patient who could be a good fit for the program, they introduce collaborative care and refer the patient, ideally through a warm handoff, to the behavioral health care manager. This referring provider is ultimately responsible for the patient's care and prescribes medications when indicated and accepted by the patient. This person receives recommendations from the psychiatric consultant. However, they alone determine if those recommendations will be presented to the patient for consideration. Also forgot to mention, if you have questions throughout the presentation, please feel free to raise your hand or type in the chat, and I'll be monitoring those for myself and Dr. Music so we can address those at the point that you have the question rather than waiting until the end. So the next role for us to look at is the behavioral health care manager. This person coordinates the overall effort of the group and ensures communication among team members. We like to think of them as the quarterback of the collaborative care team. They're managing the caseload of enrolled patients. They receive those referrals from the primary or specialty care provider. They complete further assessment, provide brief interventions such as motivational interviewing or behavioral activation. BHCMs do not act as traditional therapists, which is difficult because there are very few people across the country who have been implementing collaborative care in the role of a BHCM, even though the model is more than 20 years old. But they do utilize therapeutic interventions just in smaller bite-sized chunks for the patient. If the patient is on medications, the behavioral health care manager also supports medication management. The BHCM tracks how the patient is responding to treatment by routinely readministering those outcome scales, the PHQ-9 or GAD, or we'll talk about some others that are possible for this population as well. And this allows the team to adjust care for patients who aren't improving. The BHCM supports the patient in learning how to manage their symptoms independently through self-management planning, safety planning for suicide prevention, and relapse prevention planning as appropriate. And finally, the behavioral health care manager meets with the psychiatric consultant. This meeting is typically weekly for an hour, but may increase or decrease in length or frequency as the BHCM's caseload gets larger or smaller. So the psychiatric consultant, like I just mentioned, the psychiatric consultant meets weekly with the behavioral health care manager to systematically review patients that are enrolled in the program. During this meeting, they focus on patients who are new to the program, not improving as expected, need medication or other treatment adjustments, possibly patients that need a higher level of care, or patients whose care has not been reviewed in the past 4 to 6 weeks. The psychiatric consultant provides recommendations to the behavioral health care manager and the referring or specialty provider. This extends beyond recommendations on medications. Patients do not need to be on medications to be served in the collaborative care program. The psychiatric consultant may recommend further assessment, non-pharmaceutical interventions, or other approaches, possibly, different lab work additionally. And through this process, the psychiatric consultant educates the referring provider on psychopharmacology for these types of patients, increasing their comfort and capacity to prescribe medications over time. In collaborative care, the psychiatric consultant is truly a consultant to the treatment team. They do not see patients directly, and they do not prescribe the medications themselves, even though they're qualified to do so. We can't leave out the role of the patient. Collaborative care hopefully engages the patient, encourages them to be active in their own treatment. The patient decides whether to enroll in the program, and they maintain the autonomy to determine which types of treatment they want to accept. Many patients in collaborative care do not want or need medications. The patient reports their experiences and the outcomes of the interventions. That includes what worked and what didn't, and any symptoms or side effects they're experiencing. The patient takes an active role learning about the diagnosed condition and creating self-management and relapse prevention plans with the behavioral health care manager. So with that, I want to turn it over to Dr. Music to talk a little more specifically about the collaborative care model with perinatal patients.
Okay, thank you so much. Not sure whether my camera is gonna show as well, or if not, you just hear my voice.
It is. We can see your video.
Oh, okay. I don't see myself. So wonderful. It's good to be with you. Thanks for having me. So I will walk you through some of the kind of specifics of the perinatal collaborative care model, and starting with who are good persons to refer to this program in what is perinatal period. So this is the time in pregnancy, birthing, postpartum, up to 1 year postpartum, as well as individuals who had experienced the reproductive loss could be part of your service. It's dependent whether this is part of your specific clinic as well. But in general, we include women with perinatal loss as well. And the definition of postpartum is, we will talk about that, is variable in the DSM. There's a specific criterion, only the first couple weeks postpartum up to 6 weeks. However, in general, in the perinatal field, we take the first year postpartum as defined as postpartum period. And then in terms of the appropriate diagnostic severity, I would say it's the mild to moderate co-occurring mental health needs, which is predominantly anxiety and depression. And that can be active or historical per chart, as defined by the PHQ-9 or GAD-7. And mild, you will see the scoring is defined as scores of 10 and above, up to a score of 19. However, there's flexibility in what kind of patients you might want to manage, because diagnoses are a little bit more complex in the perinatal period, and we'll talk about that. And so you might also include individuals who show post-traumatic stress disorder, or maybe more adjustment disorders and do not meet specific criteria for major depression. Next. So thinking about the boundaries of the perinatal patient, again, it's in the perinatal period, things are not so black and white in terms of diagnostics. The hormonal changes that happen across the pregnancy and then with the birth, this sudden drop of the reproductive hormones, particularly estrogen, creates a vulnerability to mood fluctuations. So we know that this drop of estrogen specifically leads to a mood swing. We call this the blues. The blues per se is not an illness, but that might lead into an illness state if someone has pre-existing condition and genetic loading. And so with that, it's very important to be aware of kind of mood swings already in pregnancy, and that might then lead into postpartum. What we usually want to address are mild to moderate symptoms of illness, but some patients might have just adjustments to this birthing process or the birth or the postpartum, might have grief reactions or reactivation of traumatic experiences that are relived and might not even meet criteria for major depression or generalized anxiety disorder, anxiety, NOS. And so depending on your program, you might also have individuals who have grief, loss, adjustment difficulties, mild symptoms, and you might not want to give a diagnosis because persons are sensitive to being pathologized and labeled, but you might still include them in your program in support. They might not need medicines, but support. So use your clinical judgment. Who would be a good patient in this service? Moderate symptoms may also fall into this diagnostic category. As I said, it's more complex. Sometimes mood swings that look more like bipolar 2 disorder, so depression with some mild mood elevations. You might or might not want to include them. Bipolar per se, we are trying, we might not include them a priori into this collaborative care model, but given that there's a lot of overlap and sometimes mood swings are part of the picture, you might want to serve these individuals as well as in women with trauma and trauma experience, PTSD, maybe some with some personality features. So again, depending on your program, you might or might not include. Generally, moderate symptoms fall not into the category of primary collaborative care model. And then in terms of the OB practice workflow, so you might discuss with your practice what the best workflow is and explore which patients might be appropriate and which plan might be appropriate and what other options you have for those you don't want to include. Can you actually refer them out, or can you coordinate services with discharging patients back to the treating provider elsewhere? Okay, next. So flexibility is very important in the perinatal period. We know that, for instance, individuals who have a perinatal loss, which is not uncommon either in pregnancy or postpartum, they might get pregnant again, and you might want to include them in your service. So that's a very important, so that there is not clear boundary when somebody is included and discharged. Another piece that is very, very important is that trauma is very prevalent among women. The statistics, I'm sure 1 in 4 women is experienced or has experienced childhood trauma, mostly sexual trauma in the United States. And these past developmental relational traumas, as well as the potential for perinatal losses and such trauma, or a birth trauma, 30% of women name their birth experience as traumatic. All this might superimpose and create risk for traumatic reactions, trauma and stress-related disorders, or PTSD in a full-blown picture. And so these previous trauma experiences can be reactivated in the pregnancy and postpartum and make the picture just much more colorful, so to speak. And therefore, trauma is a key symptom pattern in perinatal. Another point is the appreciation of racial difference in the perinatal experience. We know that Black and women of color are particularly susceptible to oppressive practices or discrimination, and so this is adding to the picture, as well as to preconception morbidity that is more prevalent. And so that makes them also more susceptible for mental health problems. And we know that mortality rates and mental health morbidity and mortality rates are higher among women who are Black or brown bodies. So with that said, that's a particularly important consideration. Next. Special considerations also include thinking about medicines. So medication management, of course, is not our first line of treatment. Actually, counseling is, according to the National Task Force on Perinatal Health, the number one, both psychotherapy as well as counseling in general and supportive interventions. So the behavioral health care manager has the primary role of support and resourcing, but medications is as an important second line. But both women and provider might have strong feelings and thoughts about medicines. We have to make sure that medicines that are prescribed are safe and effective. Otherwise, this is would be there are two patients, the mother and the fetus or the infant in postpartum are the patients. So that's a very consideration. However, we have pretty good data at this point, which medicines are safe and which ones are not. So many perinatal access programs provide like psychopharm trainings or cards that are speaking to the safety. In terms of identity changes, that's another whole area that often the support is around this unique time period of excitement, distress, bodily and emotional exhaustion. The perinatal period is so, again, colorful in terms of all kinds of presentations. And we have to really appreciate the multiple functions or the multiple challenges that families undergo. It's the mom, it's the dad as well. We know that 30% of the dads get depressed as well. And so if mom is depressed and the dad then as well, then it's a whole family matter. So thinking about all these multiple role changes, identity changes from a working person to a stay-at-home person who cares for the baby, for body changes that are happening. All this is very important. So I think that's kind of this whole area. And then there are cultural differences depending on the familial and cultural background, pregnancy, birthing, postpartum breastfeeding, have different cultural and personal and familial meanings. And this needs to be explored. Attitudes need to be understood, and only then can we really address and support the patients. Okay, next slide. So what about severity? So we have two screening scales. That's the PHQ-9, which is a depression, and the GAD-7, which is an anxiety screener. Scores of greater than 19, and you will see the scoring in a minute, would be meeting a severity level that usually is not meant to be appropriate for this model, as well as patients who, so one, the severity. Second would be patients who, after a while, let's say, usually we say 8 to 12 weeks of care in this model, are not showing the improvements that we are looking for, despite monitoring, despite treatment adherence. That might be the point to think about referring out to higher level of care. Patients also who are struggling to function and can't care for themselves or their children, despite the support of this model, might need a higher level of care. So in the various states, we have these different, kind of enhancements of care, which is intensive outpatient programs or partial hospital programs, mother-baby units, as well as maybe inpatient. Patients who have safety risk. So the main safety risk that we are all concerned about is active suicidality. So that would be suicidal ideation, suicidal intent, suicidal plan. That is definitely something where you might want to advance level of care. Comorbidities such as active substance use. Sometimes in some clinics, patients with prior substance use who are in recovery are appropriate or might be deemed appropriate, because actually this is quite common. As we know, 10% of persons in pregnancy are either using tobacco or alcohol. So they might have had previous exposures and might be in recovery. So we might consider those to be deemed appropriate. Individuals with active psychosis, so that could be delusional disorders, that could be active bipolar illness relapse, mania, or schizophrenia, schizoaffective disorders. So that might be, again, needing a higher level of care. Individuals with significant developmental disabilities. Again, this is depending on your clinic. Neurodivergence is a pretty common occurrence, so we usually don't screen for this in the general clinics. But if there is a severity level, you might want to do more testing and then find this not appropriate for this model. And then personality characteristics that might be interfering with functionality and kind of being able to be managed in a collaborative care model. Individuals, with PTSD, we already talked about that people with severe trauma reactions might also be, if they're very unstable, might not be appropriate. Next slide. So what is the definition of perinatal depression? You know that major depressive disorder, according to the Diagnostic and Statistical Manual, 5th edition, this is our kind of model, how we think about this. And you have to have 5 or more symptoms within the same 2-week period, of which one has to be at least one of those 2, either depressed mood, often it's irritable mood, which is also okay, and or loss of interest, pleasure. We call this anhedonia. So you have to have at least one of those, and then additional ones that are listed on the right side. You might remember from your medical school or training the mnemonic SIGI CAPS, which outlines all these symptoms that are here on the right side, from sleep to guilt, excessive guilt, energy level, concentration level, appetite, psychomotor retardation or agitation. And the suicidality. Again, depression can happen during pregnancy and postpartum. And while DSM puts these strict timeframes of postpartum, it has to be onset within the first 4 weeks postpartum. We actually, in the perinatal field, are much more loose on these definitions, because usually these relapses happen or the new onset might happen anytime during the first year of life, and it's okay. That's what we call postpartum. Next slide. So the PHQ-9 is our standard screening tool, and I know it's also different systems require this, like Blue Cross Blue Shields, that this is the screening tool. You have, over the last 2 weeks, you are asking for these 9 symptom clusters, and then you rate on patient self-rates on a scale from 0 to 3, from not at all to nearly every day. I want to highlight the question number 9, which is the suicidality question, that is particularly important to address, that's looked at immediately. Next slide. In terms of the scoring, so it's very typical that everybody has at least 1 or 2 of these symptoms, rates them positively, but you should have a none or minimal by 4, mild symptoms are up to 9. And appropriate for collaborative care model to get into this treatment model would be a score from 10 and above. But up to 19, everything above 19 is moderate, beyond moderately severe, and we think that that's it needs a higher level of care. And then again, please be aware of the question 9, which is the suicidality question. That might also escalate to a higher level of care. Next slide. A very common screening tool is also the EPDS, or Edinburgh Postnatal Depression Scale. That was actually the first one that was specifically developed by John Cox in 1987 for the perinatal period. Is also very validated, but it's really clinic specific whether the PHQ-9 or the EPDS is used. And these are, again, 10 questions. The last question, number 10, is the one that is the suicidality question, needs to be taken very seriously. And here it's, again, scoring from 0 to 3. It's sometimes reverse coded, but at the end of the day, the score goes from 0 to 30, and everything, next slide, above a 13 is considered most likely, major depression. So 14 and above is probable major depression. Below, around score 10, which would be appropriate again for collaborative care model, is a minor depression, so subsyndromal major depression. And again, your clinic will make the adjustment. What is appropriate for your clinic? Question 10 is the suicidality. Okay, I want to transition to perinatal anxiety. Anxiety is actually as common, if not more common, in the perinatal period than depression. And it kind of looks like what we in DSM call generalized anxiety disorder. So generalized anxiety is characterized by excessive anxiety and worry, racing thoughts that are ongoing most of the day, all day long, about basically everything, every a number of events or activities, and the patient cannot control these worries. They are basically nonstop. They are excessive. They are impairing functionality, and they come along with some somatic symptoms. So restlessness and being keyed up, feeling fatigue, because when you worry all day long, you get tired, and the body is exhausted, and you can't concentrate, and you're irritable, and you have muscle tension, and you can't sleep. And in DSM, we asked that this symptom or the syndrome is 6 months or longer. Well, in perinatal, we are less kind of tied to this long this longevity. We think that usually when you have 2 weeks kind of this worry and this anxiety, we already call this perinatal anxiety, because it comes on very quickly in the perinatal period and gets quickly bad. And so we name this perinatal anxiety, although there is no equivalent like a DSM-5 specifier perinatal anxiety. But it basically looks like generalized anxiety disorder. We can diagnose as anxiety disorder NOS with perinatal onset. And often the content of the worry is very specific to worries about the baby, worries about being a good mom, worries about the family, and all these topics that are related to parenthood. Next slide. So how do we screen for this condition, perinatal anxiety? We use the GAD-7 because actually the symptoms are very similar. And it's, again, 7 questions that tap into that cognitive and somatic experience of anxiety, rated from 0 to 3, not at all, to nearly every day. It's again asking over the last 2 weeks. And next slide. The scoring, if you have a 10 and above, that would be, again, appropriate for the collaborative care model. we think up to a score of 19. And then if it's beyond that, sometimes the anxiety gets so debilitating and so severe that actually a higher level of care might be needed. That comes along then with panic attacks, OCD kind of symptoms like intrusive thoughts, thoughts of wanting to hurt oneself or the baby. So these are maybe moments where you might think of bringing in a higher level of care and refer out to psychiatry. Okay, next slide. I think that what is very important to me, and this is basically, something that the importance is the more trauma and social determinants of health your patients have experienced across the lifetime or in the here and now, the more you will see comorbid conditions. So in the clinics that I serve or the collaborative care model that I support, we actually see all this comorbidity in the same presentation. We have women who, because they have adverse childhood experiences from their lifetime, and as again, you know that 20% of people have 4 or more ACEs, which is, on a scale from 0 to 10, what ACEs is kind of historically has been looked at. If you have a lot of those, you are more likely to have depression, anxiety, PTSD, and then medication with substance use and misuse in the same picture. And so there's an overlap of at least 30 to 60% or 80% between substance use and trauma. So be aware that sometimes it's beyond just depression, but sometimes the depression is our entry point, and then we ask about all the other things as well. Okay, next slide. And with that, I want to tell you a little bit about our collaborative care model and perinatal access program in Michigan. It's called MC3 and stands for the Michigan Clinical Consultation and Care Model. So these are the 3 C's. And under this umbrella, we have 2 services, the perinatal and the pediatric. And the main idea of this program is to offer psychiatry support free of charge to health providers in Michigan. And these are primary care providers who do behavioral health management for their patients in OB or pediatrics or primary care. So the perinatal service provides now 2 functions. One is the provider consultation that I just said, that also pediatrics does, where we do same-day psychiatric consultation for providers who care for perinatal patients. So they might call in and have a medication question. What is safe and effective in pregnancy or postpartum? And we do the same-day phone consults. We also do trainings, webinars, we have toolkits, and that's statewide, and it's no cost to any provider can call in for no cost. In addition, we also have a perinatal patient care collaborative care model that we are running as a pilot currently in select counties in Michigan. And that service, the same day free access to basically a collaborative care model, but it's all virtual. So we screen for risk and needs. We do brief consultation and brief therapy. So again, it's kind of a therapy that only targets 6 to 8 sessions, case management, resourcing, care coordination with the provider, mostly it's OBs or pediatricians, and then symptom monitoring with a registry up to 12 months postpartum. Again, free of charge in select counties in Michigan. And I'm the director of this model, so I can tell you a little bit about our data. Next slide. Michigan is part of this national network of perinatal psychiatry access programs. I see that your program is also has an active, your state has an active program as well, an access program. So that's a wonderful, occurrence nationally. And the umbrella is called the Lifelines for Moms group. Next slide. So MC3 collaborative care model, how this works, our behavioral health care managers or consultants are not integrated in clinics in person, but virtually, in such that there are these flyers, and in some clinics we have an app, but mostly it's flyers with a QR code that are hanging in clinics, and the provider informs the patient. The provider does, again, the same kind of screening, discussion with the patient, and then says, you might be available. If you are interested, you could access this program, and then the patient basically scans the QR code from the clinic or from home, and then connects basically immediately to a provider, to a care manager, the behavioral health care manager, who gets a text alert, connects then via text with the patient, and then they arrange a time to meet virtually, and then they do an e-screening, and then they start work together. They are enrolled in the program. Next slide. So we have data from the last 2 years where we started this. We started this in 2022. We have received referrals of 540 women. We engaged 94% into the program. 75% went to the stage of wanting also clinical, like these sessions in these therapy sessions, so to speak. The demographic, you see that it's pretty diverse and actually high risk. So our service is and a little bit unusual in that regard. So that's what we chose, is to serve also those who have more severe and also other comorbidities. So trauma. We have 20% intimate partner violence, 30% have substance use disorder, 16% have active use. We do not make them ineligible. And then you see that our sessions, our behavioral health sessions, are delivered in different modalities, from phone, video, chat, texting, email, or in some cases even in person. On average, patients receive 6.7 sessions, and we are currently piloting this. You hear a graphic of Michigan in our Southeast Michigan region. The idea is to expand it statewide. Next slide. Here we are tracking our scores. We do use the PHQ-9 at baseline. This is month 1. This is when they get enrolled. You see the average score is 10.3, and then the score drops we have here 5 months sketched out. How the scores drop, patient gets better. On the right panel, you see how many patients met clinical cutoff above 10 of moderate depression, and you see they start with 50% and drop to 20% at month 5. Next session means service in how many of these kind of intervention sessions they get. So or a resource session. We are counting all of it, and currently we are doing sub-analysis. What kind of sessions are yielding what kind of drop in symptoms, to make sure that, is it resourcing, is it more kind of therapeutic, is it more care coordination that is actually driving symptom reduction. Next slide. This is sketching out anxiety with the GAD-7. So again, you see on the left panel, it's the mean scores for the continuous score. On the right side, right panel is how many meet criteria above the cutoff of 10. And again, you see a drop in symptoms, and yet we are currently doing sub-analysis. Who are the 22% of women who are not getting better? What about those? What is the characteristic of those, and how can we better serve those? One thing that I can tell you, that I already did sub-analysis, I thought, well, is it that the women with substance use risk and with IPV and trauma, are they the ones who are not getting better? And it's not. So everybody gets better, even those with higher risk at the beginning. At this point, we are analyzing what other characteristics are for women not to get better? So I cannot answer this yet, but stay tuned. This is very important to us. Next slide. In terms of patient satisfaction, I can say I'm very proud to say that the women feel this is helpful. So across the board, they say this has helped me. I would recommend it. It met my needs. It lived up to my expectations. I'm satisfied. Next slide. These are some testimonials. I think that's, again, warms my heart that women talk about that this was important. The behavioral health care manager understood their need, was also able to kind of get them connected also with medical care, addressed their mental health and their medical care. Many, many stories where women otherwise would have fallen through the crack also for their physical health needs. And also that they felt understood, and that they felt that they could take a step back and kind of think about their feelings and be understood and reflect upon. So next slide. From the provider side, that is also important that the providers feel that this is helpful. So here you have in dark green, strongly agree, and in light green, agree. Basically, everybody from the provider side said, yes, I agree that this is helpful. Again, I mean, wonderful. I would recommend this program to my colleagues, 100%. I'm satisfied with the service for my patients, 100%. As well as they feel like, it met my expectation, lived up. Basically 2/3 of providers feel like I strongly agree that this is helpful. Next slide. Again, provider testimonial. I love that it loops in the provider if anything comes up. So we have a very close collaboration with the providers who refer for this. And we have, communication is very important. The diverse background of the BHCs, so behavioral health consultants, we have a very diverse group of consultants, behavioral health care managers that match also the demographics of the counties we serve. And that's very important to our providers. And also, we do a lot of teaching as we are doing the consultation, and through the behavioral health care manager who meets weekly with the psychiatrist, they get teachings, and then they teach basically back to the providers, to the primary care providers, or they can call in our the psychiatrist and consult with them directly. I feel like that the providers respect that they learn as they go on their time. That's very important to me as well. I know everybody's super busy, and they need that we meet them when they are actually available, and it's easy accessible for them. Okay, next slide. I think that's it. Yeah.
So we have about 10 minutes left for questions. I'm going to stop sharing my screen just so we can see each other if there are questions or comments. I know there was some great discussion happening in the chat earlier. Feel free to either type in the chat or raise your hand if you have questions or comments. The MC3 program really is fantastic in that it offers those two kind of branches of perinatal services, the psychiatry access line and the pilot for perinatal collaborative care. One possible difference than if you were to try to implement this yourself in Arkansas with perinatal patients is that because Dr. Music's program is funded by the Michigan Department of Health and Human Services, they are not using the collaborative care billing codes at this point because they haven't had to.
Yeah, that's right. Okay. Sarah, shall we go about this? I see there are comments in the.
Sure. Why don't I read you the questions, and then if we have time,
Yeah.
I'll circle back up to the comments. So question from Nicole, what do the text or email sessions look like, and what length are your virtual phone or video sessions?
Well, it's totally, so the texting often is resource exchange, questions, quick back and forth. And we have seen kind of an unfolding. Often initially the moms use a lot of texting, then they transition to phone calls when they feel more comfortable, and then they transition to video chat, or a kind of maybe even 1 or 2 or 3 kind of video chat sessions where they discuss maybe even more, deeper issues, or are amenable to being referred out to the community. If somebody has high needs and might need more than 6 sessions of something, we are working with them to make sure that they land in the community with some longer term care, whether this is home visiting, whether this is recovery coaches, or recovery-oriented therapy, or clinicians in the community, or CMH, community mental health service. So we're making sure that they land. But we keep monitoring across the first year, because sometimes they drop out and then they land back with us. The second piece that is very important to me is the flexibility. Some moms want once a week kind of check-in sessions. Some moms say, I have no time for that, but can I be like on the go twice a week, 15 minutes? Or can I just text in with you or check in with you when I need you? Everything goes. We feel that peripartum is that's about this flexibility. Peripartum is so challenging. If you have multiple kiddos and you are single and you have all these psychosocial things in your life, you have no time for standard traditional care models. So we are flexible to adjust to what they need. They are in the driver's seat. I hope that answered your question.
That's incredibly helpful. Thank you so much.
Yep.
So we have another question, Dr. Music, and the question is, do you mind sharing your budget and sustainability plan? Will the state pay for these services indefinitely?
Well, good question. So, well, the budget is a little bit tricky because it has multiple components. It has a strong evaluation component. It has a strong outreach component and PR marketing component to make it, to market this program. So that might not be necessary for other, insurance-based services. And then there is clinician components, so the clinical service component, where currently we are employing 5 behavioral health consultants. Each of them have on average 40 to 50 patients that they serve, and in different levels of intensity of care. So that's yeah, and then we have currently for the consultation, we have several psychiatrists who part of their FTE, like 5 to 10%, are doing the phone consultations across the week, and 5% is collaborative care, like panel reviews. So approximately 2 psychiatrists, 10% FTE. So it's kind of just for the clinical service, it's one piece of budget, and then for outreach and education and the phone consultations, a different budget. So it's a little bit difficult to say. In terms of my sustainability plan, two options: currently negotiating with legislators to make this a standing component of the budget, as in many other states. All these collaborative care models across different states, different budget and sustainability models. Some are written in the budget line and are basically anchored in the state budget. The other one would be to kind of sell this model to insurance carriers, give our data that it works, and that it works for those who otherwise fall through the crack. Even if and we sub-analyze. So what about the ones with mild to moderate? And what about the ones with moderate to severe or severe? Currently, we are serving these 3 categories, and we are analyzing who needs what. And then we can see how we best market it and, kind of source out.
So I see we have a hand raised. Wanted to introduce everyone to Carla Metzger. Carla is my direct supervisor and our program manager on the PRISM team. So Carla, what would you like to add?
I just thank you, Dr. Music and Sarah. This has been a great presentation. In terms of sustainability in Michigan, in addition to Dr. Music's fabulous collaborative care program that's funded primarily through MDHHS, we are lucky all of the major payers in Michigan are now reimbursing for the collaborative care codes. So then that includes Michigan Medicaid, although our reimbursement rates for Michigan Medicaid are not phenomenal. And so we're so very grateful that Dr. Music's team has been able to engage with the Medicaid community so actively. And in addition to the payer, all the major insurance payers paying for collaborative care, the PRISM team has been very fortunate to work with Blue Cross Blue Shield of Michigan to roll out collaborative care throughout the state. They've really been incenting practices to and health systems to adopt collaborative care, including with the perinatal population. So we have actually, with under Dr. Music's leadership, have actually developed collaborative care training that we train those serving the perinatal population. So it is sustainable. I don't know how things are shaking out with your payers in Arkansas at this point, but at least in Michigan, collaborative care is sustainable, including with the perinatal population.
Thanks,
Thanks,
Carla.
Carla. Yeah,
I'm going to
great.
go back to some earlier comments in the chat, and Carly, I'm going to put you on the spot. Your comment said, I'm in Arkansas and we provide maternal health care as part of our Arkansas Moms program. And then later on, somebody's saying, hey, I'm in Arkansas, but I've never heard of this. You know, sounds amazing. Where are you practicing? So Carly, I'm wondering if you would come off mute and just tell the group a little bit about the Arkansas Moms program.
Oh, there's something in the chat. I think maybe Carly cannot talk.
Yes. Okay. Fantastic, Carly. I'll read that out loud. So we are a grant program called Arkansas Moms through CHI St. Vincent that travels to Southwest Arkansas. We have 10 different counties that we serve with prenatal care once a week, every 2 weeks. Carly is the family development specialist that help moms gain access to resources and care through a biopsychosocial approach. She works alongside their nurse and nurse practitioner who provide their prenatal care. We're on board with this approach, but struggle also with sustainability. Yes, those are always the major questions.
Yeah. Yeah.
Fantastic. So some connections happening in the chat. Dr. Music, there was one more question or comment at the very beginning that I'll read now, and maybe you can give the Michigan perspective. So Jacqueline is saying, in Arkansas, the assessment for moms post-birth is done by the pediatrician. And she says, as someone who experienced postpartum with my first, I still don't understand why the pediatrician is the one to assess the mother's mental health needs. Women are told that the OBGYN is for the mom and the pediatrician is for the baby. Are there conversations happening about shifting that responsibility to the OBGYN? Or in your perspective, is that different in Michigan?
Well, I would say that it is more and more the obstetricians are changing also their care models, both in pregnancy as well as in postpartum, making the care models more adapting to the whole time period needs. So maybe for those, not everybody needs 14 prenatal sessions, right? Prenatal visits with an OB, and the lower risk moms, both medically and mental health wise, maybe would be okay with 6 sessions and some self-monitoring of blood pressure and such, and instead shifting some of these care models into those who need it prenatally as well as postpartum. In Michigan, with the expansion of Medicaid also to 12 months out funding, many obstetrical practices are now extending OB beyond the 6 weeks postpartum mark. And we see women, their models where then there is a 6 months visit and then a 12 months visit with the OB. So I think obstetricians are more and more understanding. We have to, not the old model, right? Everybody cares about the mom while she's pregnant, and then postpartum, the mom is, everybody's like focusing on the baby and the mom gets dropped. So keeping the mom in the focus and the baby in the focus and the diet in the focus, or the whole family in the focus, by OB, pediatrics, also working together. So we are currently working on models to cross network all these providers by some aspects are like shared epic kind of cross linkages between the infant chart and the mom's chart. That's one idea. Other ideas are bringing pediatricians and OBs into the same space of training and cross communication. And then for the obstetricians to expand their workflow postpartum and moving maybe some of the visits. The 2-week visit, yes, it's great for some moms, is important, but actually from a usual perspective, other than the risk for postpartum hemorrhage or other blood pressure issues, the 2-week visit is actually too early. You don't really need that visit. Could you have it a little bit later, and could you move the 6-week visit to 6 months and kind of stay more in touch with the mom, and then add a 12 months visit? So that's kind of a long-winded answer to that yes, we need to be more aware, and the OBs need to work harder to stay in touch with the moms.
Thank you. And Kim, I'll turn it back over to you because we're just at time for final comments.
Absolutely. Thank you, Sarah. I just wanted to address the last comment. Someone said, this is a fantastic presentation. Could we bring this information to Arkansas Blue Cross? And just wanted to invite everyone on the call. We do have a COCM monthly stakeholder group where we have health systems, payers, providers, and we would love you to join that group if you have an interest. Part of today's presentation came out of a need for addressing perinatal patients in the COCM model. So that's why we're bringing this presentation today. Please join us. We will, maybe Jenny could put our website link in the chat, and Misty's got it. Here's the Zoom link for those monthly calls. We also wanted to say thank you. The state of Arkansas has received a COCM grant, and so they are looking carefully at the COCM model and what that can look like for Arkansas. So want to keep everyone posted. That is happening. And then I just want to say thank you to Dr. Music and to Sarah and the PRISM team for putting this presentation together, for joining us from across the world and bringing this presentation to us. It was extremely helpful. And this is exactly what we need to do. We need to be bringing in all of these innovative programs that are effective and evidence-based, and we're seeing such amazing outcomes. And think about what can we do in Arkansas, and how can we lean on our partners across the country to help us bring these bring this work to Arkansas. With that, thank you. We appreciate your time, and we look forward to continuing the conversation. Y'all have a wonderful day.
Thank you very much, everyone. It was great being with you. Thank you. Hopefully see you soon.
Yes. Bye-bye.